where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone. Welcome to UroNurse. I'm your host, Vic Senese. Glad to have everyone on board. It's getting to be summertime. Hope you guys are all doing something fun besides watching this. And if you're watching this and you haven't liked and subscribed, what are you waiting for? Like and subscribe. Hey, we got a great show for you today. I'm going to actually be presenting, but first let me bring in my co-host, Lori Atkinson. Lori, welcome to the show.
Good morning, everyone.
Lori, we haven't seen you in a while. Why don't you fill everybody in on what you've been doing to have fun?
Well, I've actually been inside my house for probably the past 7 weeks now after an injury where I basically ripped a tendon off my ischial tuberosity skating, and I did the splits unintentionally. So I have been out. I had surgery. I'm doing well. I am now walking and hopefully going back to work in about a week or so as soon as I get my stamina up. So I'm glad to be back. Missed you guys all.
Yeah, we're glad to have you back. So as I said, it's been a while since I've spoken on UroNurse. So today I decided I'm going to discuss paraphimosis, a urological emergency that healthcare professionals should never overlook, often preventable and sometimes unintentionally caused, sometimes by us, during routine care. So rapid recognition and treatment are critical. Hey, you know, it's kind of fun being back in the driver's seat, so let's take it. All right, so here we go. Paraphimosis. Paraphimosis is a urologic emergency you can't afford to ignore. Often caused unintentionally by routine nursing care when the foreskin is retracted and not returned to its normal position. It can quickly lead to severe swelling and tissue damage. The good news is nurses are also the best ones able to recognize it early and provide timely care that can prevent serious complications, which is why we're here. So let's start by discussing the difference in phimosis and paraphimosis. Both are foreskin-related conditions, but they differ significantly in presentation and urgency. Now, phimosis is the inability to retract a non-retractable foreskin over the gland's penis. This can be due to physiological reasons or pathological reasons, such as scarring, inflammation, or chronic infection. Typically presents with like a ballooning when patients are trying to urinate, and then it trickles out after that, or difficulties pulling it back to clean it, recurrent balanitis, painful erections, all signs that you may have a phimosis. Remember, the key is this is not emergent. You can't pull back the foreskin. Paraphimosis, however, that's a urologic emergency in which the retracted foreskin becomes trapped behind the glands and cannot be returned to its normal position. That leads to progressive swelling, venous and lymphatic congestion, and potential ischemia of the glands. Requires prompt reduction. The key clinical distinction is that phimosis is a chronic, non-emergent inability to retract, while paraphimosis is an acute, potentially ischemic entrapment, acquiring immediate intervention. So the most common cause of paraphimosis it's us, folks. How? Well, you go and you do that catheterization and you fail to return that foreskin back over the head of the penis. Guess what happens? It blows up like a balloon. Or maybe you're just doing helping with a cysto, and after the cysto, they forget to pull back that foreskin. You know, even nowadays, sometimes it's hard to tell if somebody's been circumcised or not. Ask, are you circumcised? You'd be surprised. Sometimes it looks like they're not circumcised, and it's just the foreskin that wasn't returned. So make sure you return that after you put that catheter in. Now, when the foreskin is left retracted behind the glands, it forms a constricting band that impedes venous and lymphatic return, leading to rapid edema of the glands and foreskin and potentially progressing to arterial compromise if not corrected promptly. This risk is especially elevated in patients who are sedated, cognitively impaired, or unable to self-report discomfort, making post-procedural foreskin repositioning a critical step in safety for urologic patients. Now, as we see right here, this band is what we're talking about. When the foreskin is retracted behind the glands of the penis and not returned to its formal position, a tight phimotic band can form behind the head of the prostate, constricting band. Now, if that happens and the foreskin remains trapped, venous and lymphatic drainage from the glands becomes obstructed, leading to progressive swelling. So we know that as blood doesn't get past this, it starts to build up. This swelling further increases constriction. Yep. Which can then lead to reduced arterial blood flow. Now, as we kind of see here in this picture with the head of the penis starting to turn black, there is a risk of ischemic injury. So prompt recognition and immediate reduction are essential to prevent tissue injury. Now, a healthy prepuce is supple, freely mobile, and able to retract over the glands without pain or cracking or constriction. Clinical hallmarks of an abnormal prepuce includes a tight fibrotic or inflamed foreskin that cannot be retracted over the glands, or a retracted foreskin trapped behind the glands with distal edema and possible cyanosis. So as you can see in the picture, it really does seem like a ring right there. Now, the escalation protocol. Boom, boom, boom. The escalation protocol for rapid reduction of paraphimosis should begin immediately upon recognizing that there's a paraphimosis forming. As the more you delay treatment, the harder it's going to be to reduce and the greater the risk for ischemic injury. So initially, manual reduction. First step, you want to try to do something to get that foreskin back over the head of the penis. Usually it's going to be a squeezing technique. We'll talk about compression. That doesn't work. There's an osmotic therapy we can then go to. That doesn't work. Then we call in the urology group. They can try things like puncture aspirations, injections, and usually it ends up leading to a surgical procedure called a dorsal slit. We're going to go over all of that. So let's start here. So sustained compression, number one, key. If you can squeeze this foreskin so you get the fluid out of it, and that usually means you got to put pressure on it for 5-10 minutes, just physically squeezing it. Now remember, this patient's in pain already, so squeezing that's not going to feel great. But I found that most patients tolerate it because they know that there's relief to follow. Now here's a picture that I came up with so I could not get taken off of YouTube of how I do this. I just kind of, like you can see here, like I'm doing on the sausage, you grab the penis and just hold and squeeze, especially at the head of the penis. You want to be able to squeeze that fluid down past that phimotic band. Keep it on there for about 5-10 minutes, that pressure. Patients, I find if you use, I like conversation as an anesthetic. Talk about something. Don't just sit there holding it. Come up and involve them in, in some kind of conversation. There's got to be something to talk about, right? Then you go to manual reduction once you've squeezed some of that fluid out there. Now that's the technique I like to use right there. So you can see I'm pushing with my thumbs and pushing the head of the penis down into that foreskin. And you kind of have to do this type of maneuver. So you're kind of grabbing the foreskin with your fingers on the side, and then you're pushing down with your thumb to get that to pop through. Nothing's as satisfying as when you feel that pop as the head of the penis goes through that phimotic band. It's really great. If you never did it before, you're going to enjoy it because patients really like the relief. It's like instantaneous. They feel better. They also talk about a little lubricant, maybe on the head of the penis, but I find if you use too much lubricant, you're slipping all over the place. Now, this one I've never performed, but they say if manual pressure doesn't work, then you can use science. The trick of osmosis by putting sugar, good old sugar out of a pack of sugar on the glands itself, and it'll helpfully, over time draw out some of that fluid through osmosis. Again, never tried it, but it's in the literature. I thought I'd include it. They also talk about soaking a gauze in dextrose and lidocaine. Little anesthetic, never hurts. 50% dextrose to 1% lidocaine in a condom for an hour. Who knows? Maybe next time I have a chance, I might try that. Cost effective, often spares patient a surgical procedure. They're happy for that. Now, if patients are having a lot of pain, we shouldn't hold back on the anesthesia. So we can have a block, a dorsal penile nerve block. Now, I've never given one of those, so usually it's our urologist that'll come in and do that. But if you're having a block done, we inject at the 2 and 10 o'clock and 2 o'clock position at buccal fascia at the base of the penis. It basically numbs the whole penis. It's what we do for circumcision, same thing. Here's a big thing, 1% lidocaine, like it says right over there, without epinephrine to avoid, you don't want, the epinephrine causes vasoconstriction. We don't want that. Now, here's another technique I've never done. Again, found it in the literature. Makes sense. So this one, I think, is once you call the urologist in, and that's a technique where they puncture little holes in the penis with an 18 gauge needle to help that fluid just literally drain out. Give it a squeeze. After you got the fluid, should be able to reduce it. There's another thing where you can use an enzyme called hyaluronidases. It's an enzyme that breaks down hyaluronic. Wow, I have trouble with this one. Hyaluronic acid in the interstitial space. That's going to increase permeability and help get rid of that trapped fluid. Again, never tried it, but it's in the literature, so I thought I'd mention it. Now, this one I have assisted with plenty of times. So when all else fails, then the urologist gets in here and we do a quickie dorsal slit. Simple procedure, local anesthetic injected first. You can see we put the hemostat right in here at the 12 o'clock position. Give it a squeeze to crush the skin. Once you crush it, hemostat stands for stopping bleeding, right? So once you do it, you can then make a cut with the scissors right across that bridge, right across that ring, and go ahead and sew those edges up. And it's pretty quick and you can have complete relief, immediate relief. Not the greatest cosmetic look, but sometimes we go on to circumcision or a more formal dorsal slit. So key things to remember on your checklist. We cannot afford to wait and see with paraphimosis. The longer you wait, the harder it's going to be to reduce. And it's a risk that you could miss that window of opportunity where you start getting ischemia. Nothing worse than, ending up with a penectomy or debridement of necrotic tissue, right? So these are life-altering complications for a condition that's entirely preventable. So what do we do afterwards? Well, successful rate reduction is only half the battle. Because the underlying tightness remains, recurrence is very likely. Every patient who presents with paraphimosis should be referred for elective circumcision or a formal dorsal slit once the inflammation goes down. And finally, educate the patient that they need to pull back and clean it. They must put it back. So kind of watching things for the first couple of days, simple analgesia. Stitches are going to dissolve 1 to 2 weeks. No sexual activity for 4 weeks. Outpatient follow-up 1 to 3 months. Sometimes we're going to try them on some steroids and eventually maybe go to a formal circumcision. So let's wrap it up. Remember, paraphimosis, the golden rule. Always replace the foreskin after the examination or catheterization. But it's a no-miss diagnosis. If you see it, act fast. Remember, you're the one who can do this. Remember the risk. Don't let a routine catheter turn into a surgical emergency. Start with pressure, move to the sugar if needed, then consult urology if that fails. Now, let's go to questions. Be sure to put them in your comment box. I'll be glad to take them. All right. Well, Lori, so have you ever gotten involved in any of these?
Many. Actually, it's funny because I've seen so many of them that, you take you triage a call and they say they have a catheter, they have pain and a lot of swelling at the tip of the penis, redness, and they are really uncomfortable. And I say, "Are you circumcised?" And they said, "Nope." And I'm like, "Come on in." And then usually I can reduce it before the doctor even comes in the room.
Yeah. Well, and that's, I think, where a lot of people miss. They think, oh, we got to call the urologist in, we got to call the physician in. And really, this is a nursing procedure that can be done, that squeeze technique by get the foreskin where it needs to be as soon as possible, because the more that it gets allowed to sit, it's going to get bigger and bigger and harder to reduce.
I've never heard of that sugar technique, though.
That was going to be my next question for you. So of course, I do the research because I'm going to be giving a talk, and I found this sugar. It makes sense. Osmosis, it probably could work. Just mix it with a little sugar on the penis and see what happens. But I'd be kind of worried about the granules and trying to work with it.
Yeah. Now, did you do the dorsal slits in your office? Because
yeah.
Oh, okay. Yeah,
Yeah,
we would end up doing like an urgent surgery on them.
we've done them at the bedside in the hospital. We've done them in the office. We just do the anesthetic, kind of injecting the base of the penis. The whole thing goes numb, and you can work quickly and fix it right away.
Yeah, I thought the poking of the holes was. Have you seen that before?
Another one I read in the literature. It makes sense, but I've never seen it done.
Yeah,
but I can imagine it looks like a sprinkler when you got all those holes in it and the fluid squeezing out. And the hyaluronic acid, I had never heard of that breaking it down either. So
yeah,
I guess it's good to report the stuff that's in the literature, but what really works is compression.
yeah.
Early compression, getting in there and getting that technique to get the head of the penis into the foreskin, that works wonders.
Yeah, as a urology nurse, there's never nobody else would be quite excited about that little pop that you feel when that ring comes over. I mean, it's like so satisfying.
It is. And the patients are happy because you've now kind of took them out of pain. So it's a win-win situation. But yeah, I think that this is something I thought, we should really talk about it, because nurses should know they should be able to get in there right away. And more importantly is prevention, because how many times have you seen somebody go and, they retract the foreskin to put a catheter in because they want to be able to see the opening, put the catheter in, finish up everything and walk out, and they never think to go back and fix the foreskin.
Or even the cystoscopies, and they don't, unless like we do, a lot of places, that's not something they teach at all.
No.
When they're doing these. So it happens too often.
Yep. So hopefully people watching UroNurse will now be educated to do it. Hey, folks, if you have any questions, feel free to put them into the comments. I'll be glad to take those. If not, that means I did a thorough job of explaining everything there is to know about paraphimosis. I'm kind of trying this shorter format too, because I think that people I went back to kind of thinking when I was a kid, when we watched TV at home, it was 30-minute shows. So not really hour shows weren't too often seen. Everybody was, you watch 30 minutes and tune in next week for same bad time, same bad channel. So I'm trying to go to that format, because I read that people are watching a lot of YouTube videos. It's actually the number one watch thing on the big television. So they watch us on their big TVs. So you want to be kind of meeting that format. And so anyway, we'll see how that goes.
Absolutely.
So I don't see any questions coming in, which is fine. So I'm going to take a little time here to chat about something come up on May 30th. Folks, we're going to hit 200 episodes. So kind of celebrated the year for a while. And then I started thinking, well, now I went to the 100th episode a while back where we celebrated that. And I don't know when this will ever end up stopping, but we're going to have our 200th episode in a couple of weeks.
That's
fantastic.
It's going
to be a fun. I know, Laura, I've asked you to join us. We'll see who else we can get to join. We're going to go over some things like what's happened in the show, how it's doing, but also some of the ideas coming up for new ideas. If you have people watching, can put in new ideas. And I got a surprise for you, because I've already got working on something. Just got a bunch of good mornings coming in here. All right. So no questions. So anyway, that's going to be our show for the 200th episode. That's hard to believe. That's almost 4 years of UroNurse.
That's crazy.
An idea that we came up, and Lori's been with us since the start. So I mean,
I enjoy it. I've learned a lot of information.
It's been amazing, just kind of, and how to present on this format, being on the video for people. It's kind of different. I've kind of had the show evolve a little bit, some different things that I've been doing. So it's been fun. All right, let me get over here to next week's promo, because if doing one of these is fun, I may as well do another one.
Kidney stones are one of the most common and painful urologic conditions affecting millions of people worldwide. In this educational episode, Vic Senese breaks down everything you need to know about kidney stones, including how they form, what causes them, the warning signs and symptoms, Vic discusses the most effective treatment options available today. Join us on May 16th at 9 a.m. Central Time to learn more.
Feel like I should have had a cowboy hat on when I was doing that.
I just wanted to say happy Mother's Day to all you mothers out there. Enjoy your day tomorrow.
Yeah, that's right. Mother's Day is tomorrow. So hopefully you'll do something fun. I don't know what we got planned. My wife and my mother-in-law plan out what they want. So
They should.
as they should. And the weather, I'm looking outside right now. It's bright and sunny and boats in the water. That's got to mean boat time coming up pretty soon. All right, Lori, well, have a good recovery, finished, getting back to normal, and glad to have you back on the show, and hopefully see you again next week. And for all those visitors out there, make sure you tune in every week for UroNurse. We'll see you all next week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.